Thank you very much. It's a real pleasure to welcome Michael to the unit as he's touring around Europe. He's a public health physician and professor of public health at the University of Otago in Wellington. And his work during 2020 to 22 was dominated by assisting with the national COVID-19 pandemic response. And as he's just told me, doing many, many interviews every day with media. He's a member of the New Zealand government's COVID-19 Technical Advisory Group and has been the leading architect and advocate for the COVID-19 elimination strategy. He's got a wide range of public health interests with a focus on infectious diseases, environmental health and improving health conditions, and has been an active researcher on the pandemic and principal investigator for the COVID-19 Research Collaborative CoSearch. And this year has launched the Public Health Communications Centre, where he's the inaugural director. So today his talk is going to focus on the learnings from COVID-19, why elimination should be the default strategy for future pandemics. And as we all heard a lot about during the pandemic of the different strategy New Zealand took compared to the UK and Europe, we're really looking forward to hearing about this from Michael. Over to you.
Well, kia ora koutou from New Zealand. It's a great pleasure to be here. Thanks, Kirsten and Jodie, for introducing me. So I think the title is hopefully self-explanatory. What can we learn from COVID-19? Should elimination be the default option? So this is just a slide I include just to orientate people to where New Zealand is. This is the map we hand out to everyone on arrival, which has the world correctly orientated. And I'm actually based where I work for the University of Otago, but I'm at their Wellington campus. It has clinical schools and also in Christchurch. And so I'm going to talk about this phase we must be in now, learning from the pandemic. I always think, how long will it be before people say, what pandemic? And even though it seemed incredibly unforgettable, intense during that period, we are very good at forgetting things. So hopefully we can document what we've learned from this experience. For me, the number one issue is around having a clear strategy. I mean, it's not just for pandemics, it's for everything. And basically that ideally is based on evidence. Then looking at the New Zealand experience, what can we learn from that? Did elimination produce good results? Comparing strategies, that's part of the learning process in the end across countries, because in a sense, it was an observational experiment in some ways of different strategies, different outcomes. And what does this mean for the future? So this is a small historic aside. This is a paper that's coming out shortly in Emerging Infectious Diseases. And this is really comparing COVID-19 with the 1918 flu pandemic. So the graph's quite small and a bit hard to see, but I'll just say the main point. So this is showing the epidemic curves. And on the top graph, you can see flu in 1918 it was the middle wave that did the damage in New Zealand and most countries. And the remarkable thing was it swept through the country in 6 weeks. It killed 1% of the population, 9,000 people, half as many as died in the entire First World War. And then it went. It didn't go entirely. It became a dominant strain for decades. It did raise the baseline mortality rate for a long time, for many years, but it had largely vanished quite quickly. Now, if you look at COVID-19, it was a very different pandemic wave. Of course, our wave is a bit atypical because the first 2 years there was virtually no cases and virtually no deaths. But in general, it's a wave that's still going on. Arguably, we're coming out of a pandemic, but technically we may still be in the tail end of one of 3 years. So a very different virus in terms of how it behaved. And this is showing something a bit more quantitative. This is cumulative mortality by age group. And you can see the top lines are the 1918 flu pandemic that did so much damage in a very short period of time. And one reason it was so devastating was this high mortality in young adults, which has been seen around the world. So it wasn't a U curve or a J curve, it was a W curve. Whereas COVID-19 is very much that J curve, that J-shaped curve with high mortality in older age groups. And the cumulative mortality from COVID-19 only approaches that from 1918 flu in older age groups, people 85 years and over. So a very different disease burden. One reason for looking at 1918 flu is that it has become the default strategy, or how a severe pandemic will behave. It will be like flu. There's good reasons for preparing for flu because it comes around about 3 times a century, a flu pandemic. But that became almost the only kind of pandemic we were preparing for. So learning from pandemics, there are a lot of papers coming out listing what the key lessons are. And I think Lance Commission papers are very comprehensive description, but there are others as well. I don't think any of them so far really capture, I think, particularly the strategic issues about what should we plan for in the future. So I've got my growing list of key lessons that I think we should learn from the pandemic. Everyone, I think, has a different set of lessons. I'm hoping that all of our thinking will converge on some consistent set of views about what this means for the future. New Zealand's doing a huge review, a Royal Commission that will report next year about, and it's got a very future focus. It's not going to rake through all the things that went wrong. It's going to think, really, what should a new pandemic plan look like? I know the UK is also doing a very detailed analysis, which obviously will be very helpful. So as the pandemic was approaching New Zealand, I think all of us with an interest in infectious disease epidemiology were looking at some of these key attributes. And certainly by the middle of January, it was very clear what the main parameters were, and they didn't change much for a year in terms of reproduction number, the infection fatality risk. It was going to be a severe global pandemic. You could do that back of an envelope calculation about what it would do if it couldn't be contained. So that was a bit depressing. But then by February, there was a glimmer of light. And I thought this remarkable report from the Bruce Aylward from the WHO produced with about 20 other scientists, half were from China and half were external scientists who went in and they said, China has stopped this pandemic in Wuhan. And this was remarkable because it was the first time, I think, in history that a respiratory pandemic like this had been actually interrupted. So it convinced me in New Zealand, and I think probably other people around the world, that elimination was feasible. And people talked about containment or various other terms, but they were more or less meaning the same thing, and that's reducing to zero, the potential to do that. But by March, it was in New Zealand, like it was in most countries around the globe. We did have a slight delay, but not very much. And so at that point, we needed to do, it wasn't just a matter of interrupting it at the border, we actually had to stamp it out in New Zealand. So there's this remarkable day, the 23rd of March, the government effectively committed to elimination. I know they pivoted from over that preceding weekend from the mitigation approach, which was built into flu management, to elimination. And they said basically the whole country is going into a national stay-at-home order or lockdown, you could say, within 4 days. We had 100 cases, no deaths. So people said, wow, that's a bit of an overreaction, isn't it? So the elimination strategy, of course, has a lot of components. The number one, of course, is border management. And this is the old idea of a cordon sanitaire around a population. The technical term, it's not quarantine. Quarantine because people haven't been exposed. I mean, quarantine is what we did at the border when people were coming in from overseas. They had a 2-week stay in a quarantine hotel. But the correct term is probably protective sequestration. But it's such a terrible mouthful, I don't think anyone uses it. But that is actually what you are doing. I think that perhaps that term should be used more precisely. But keeping it out is a number one requirement. After that, you have to have the ability to stamp out outbreaks, and that uses very familiar tools of testing, contact tracing, isolation, quarantine. And then increasingly, and particularly as you're contemplating widespread transmission, you've got hygiene measures, masks, physical distancing and travel restrictions, and then vaccination in year 2. And you also do need some kind of safety net, because some groups are very adversely affected by these measures, particularly, well, for us, it was those people who relied on external tourism coming into the country that largely stopped. So, of course, while you're making all these plans, the virus keeps changing. And this was how it did transition from a fairly consistent virus in the first year to the ancestral strain, to a sequence of variants, and then more recently subvariants. And these were obviously seen all around the world, these transitions. So as a result, you have to adapt your strategy in relation to what the virus is doing and how it became more infectious for a shorter incubation period. So we had an elimination strategy for over 18 months, suppression strategy while we had a Delta variant outbreak that was very hard to eliminate, and then mitigation during the time of Omicron. Our pandemic curve looks much the same, whatever indicator we use. We've had 4 waves of Omicron, and this is showing wastewater testing showed very similar results to the basic case surveillance. And this relies, and it's still operating, members of the public can freely access RAT tests, and they are required to enter their results onto a national database. And again, it's showing very consistent results between that voluntary behavior and what we're picking up with wastewater testing. So it does seem to be still a reasonably valid surveillance system. Hospitalizations show a very similar pattern, and mortality as well. We only saw mortality, significant mortality last year. With widespread infection, most of the country would have been exposed to the virus, and COVID-19 moved up to being the 3rd leading cause of death, accounting for about 6% of mortality last year. It's dropping down this year. It's still going to be the leading infectious disease cause of death in New Zealand this year, as I think probably is in many countries. The big unknown, I think, still is the long-term effects. And I'm only mentioning that the WHO is still talking about 10 to 20% of people experiencing mid and longer term effects. I think it's too high, but again, a lot comes down to the definitions of the case definition and so on. So I think this is going to be possibly the biggest health impact of the pandemic, but it still remains to be seen. So firstly, one of the benefits of delaying arrival of the virus was it was a chance to vaccinate the population very widely. And we used almost entirely the Pfizer mRNA vaccine, and achieved about 90% coverage in the adult population by the end of year 2. So that's prior to widespread infection. Of course, no one knew in the first year whether vaccines would even work. So this was a huge revolution in thinking. A big concern in New Zealand is about health equity, and particularly across ethnic groups. And Māori, the indigenous people in New Zealand, are 15% of the population, Pacific people 5%, and we saw significantly higher hospitalization rates and mortality rates. These are age standardized for Māori and Pacific people. And this was obviously something we didn't want to see, and there were contributing factors, and one of them is lower vaccination coverage for Māori and Pacific people. So one of the big questions is, can we compare strategies and what can we learn from that? And one of the points we had to make over and over again in New Zealand was, even though these measures were disruptive, particularly border controls, we had to say the alternative is not no pandemic, it is alternative ways of managing it. So you need to have your counterfactuals, and that's really suppression and mitigation approaches. Also, you need to think, well, what are the endpoints you're going to use to compare strategies? I mean, you've got simple things like the number of cases, which is not very well measured or consistently measured across the globe, but better things are mortality, and excess mortality is even better. Potentially years of life lost, which impacts on life expectancy, is a better measure again. And ideally, a full burden of disease analysis, which means not only years of life lost, but also years of life lost through disability. And that's still going to be one of the hardest things to measure well. It'll take a long time. But then you also got to look at the costs of your strategy. You can look at the level of loss of human rights and disruption to normal activities. And there's one scale like the Oxford Stringency Index, which is very available. I mean, it's probably not perfect, but it is an attempt to quantify the stringency of controls, and then economic disruption. And then you've got a whole lot of softer outcome measures to do with education, mental health, and things like social cohesion. So if we look at this, this is a very limited comparison. This is looking at reported COVID-19 mortality rates, and this is cumulative. So you can see in the UK and the US, it's a bit over 3,000 deaths per million, which is basically 0.3% of the population has died from COVID-19 over the course of the pandemic. And if you look at countries, Australia, New Zealand, Singapore, Taiwan is also in this group. These are basically high-income countries that are islands. So they've got obviously geographic benefits. And you can see that they succeeded in delaying the pandemic by around 2 years, a little less in Singapore's case, and then have since seen a rise of mortality. And this gives you these benefits, time to roll out vaccines, but also the other benefits you get is you learn how to manage cases better. And you might remember the huge advances, I think, from the UK, I think really informed the world about improved case management using dexamethasone, the fact that you could look after these patients on a general medical ward with oxygen, and the outcomes improved hugely. And of course, antivirals also became available. So this is moving to another indicator, excess mortality. And this is a better indicator because it doesn't depend on countries reporting mortality in the same way, because there are variations in coding. And this uses the Our World in Data site, which some of you may use, is they use a very well-established approach for this. They look at the mortality pattern of the preceding 5 years and then look at your excess in relation to that. I mean, it's not perfect, but it does give a better indicator. And again, you can see that countries pursuing elimination kept excess mortality very low for 2 years and then are more or less joining the same trajectory as the rest of the world as the populations are widely infected. New Zealand is still on basically zero excess mortality for that whole period. So now, of course, it gets more interesting when you start putting a lot more countries into this. You realize actually the world does not split into very simple categories, mainly in terms of the response. And you have in here Nordic countries that, with the exception of Sweden, I think it did quite vigorous suppression approaches, and various other countries that have responded very well, I think, and kept mortality low. And again, if you look at excess mortality, it's a similar. The countries jiggle around a bit depending on which of those indicators you use. So hopefully over time, we can start to look at how these responses differed across countries and learn from that. I haven't put in countries like Japan and South Korea, which again adopted a very intense suppression approach, which was also very successful. So looking at the price that you're paying in terms of restricting people's lives, which no governments want to do, you burn for a lot of political capital, among other things. But you can see this shows a very stark difference that New Zealand, which was pursuing an elimination approach, used these measures to basically stamp out all trace of the virus. Whereas countries, even Sweden, basically had an ongoing suppression approach. And when they said, oh, we're going to perhaps do a lockdown, which was not Sweden so much, but other countries were doing lockdowns or stay-at-home orders or circuit breakers, it was not to get rid of the virus. It was just to reduce the burden. So it was either mitigation or suppression, depending on where it was on the spectrum. Whereas in New Zealand, we're using these approaches to fully eliminate the virus. And it's a completely different approach. And I remember in that third pulse, you can see there in New Zealand, a journalist rang me up from the UK to say, we hear New Zealand's having another national lockdown. How many cases have you got? And I said, 1. And so he said, are you mad? And that was because the language was all wrong. We needed a different term for what we were doing. And this is the idea of the burning ember. You have to basically extinguish every ember or the forest fire will continue on. It's just with a very infectious virus. The other thing, of course, is when you see one case, if they're not connected to the border, you know that there's chains of transmission that are invisible. So that is the reason why New Zealand would act very rapidly whenever it saw a single case. And it was doing huge quantities of testing as well. So this is looking again at these, the level of stringency of controls. And the reason for looking at this is that New Zealand kept its stringency controls very low for 2 years. So people said, oh, you're always in lockdown, that must be terrible. And I said, no, we're not actually. We are just internal activities are unaffected most of the time. The South Island of New Zealand had, I think, virtually no cases for 2 years. And so did most of the North Island. Auckland was a bit more problematic because that was where the flights were coming in and where occasionally cases did get out of quarantine facilities. But again, that's one of the big benefits. And looking at controls in Europe and Ireland and the UK, you can see very similar variations of this theme of going more or less intense controls over time. And again, this is just showing how in a more quantitative way, in terms of the median level of stringency by day over that period. I'm sure these scales, I don't know how well they correlate with the subjective experience of feeling constrained. I think it may not correlate that well, I'm not sure. If you look at the Nordic countries, I think they're all very interesting because obviously people are looking at Sweden, which distinguished itself by saying we have minimal controls versus the other Nordic countries. But actually, it wasn't really the case when you looked at at this particular scale. And again, looking at this when it's quantified, Sweden appeared to have relatively high levels of control over that whole period. Now, this is one of the reasons that I think these controls do have different impacts, and some are less acceptable than others. And I think particularly closing schools, I think, was very disruptive, and yet they're all given the same weight. So I think that's, again, a limitation of this scale. But one of the other things we looked at, of course, was the economic impact. And this is showing New Zealand compared with the OECD average. And overall, the economy performed above average for the OECD over this whole period. And that's because the internal economy was not affected, internal tourism increased, and trade was unaffected because it could go through, they had very good procedures at the border. So that's another benefit. This was a paper that was written after just really looking at the first year, and it was saying, well, when we compare multiple countries, we see that elimination is associated with the best outcomes for health, civil liberties, and the economy. So at least at that stage, that was the case. I know this analysis is being updated, and I think over time, of course, these things start to converge, but at least at that point in time, it had very good outcomes. Now, there are huge challenges and costs of elimination, of course. And remember, this has to rely only, all you've got are public health and social measures. This is going back, you could almost say, medieval methods of managing your borders and limiting contact if you have cases and so on. And one of the big impacts, of course, is restricting inbound travel. And it does result in, we saw reduced support over time. The first year, the public was wildly in favour. They returned the Labour government with the highest majority since we introduced proportional representation. So a huge public support. But over time, that did start to fade because of the, I guess, the cumulative costs of the strategy. And also, it became increasingly a lightning rod for disinformation. And of course, and unintended consequences. But many of these costs apply to every strategy in every country. Whatever governments did, I think there were problems. This is one, I think, of the most remarkable graphs, and this is the number of people coming into New Zealand by day. It dropped from 20,000 a day down to 500, and it stayed at that level mostly for 2 years. And there were some days when no one came or left the country, and the people had to look through 50 years of records to find when that had last happened, that level of disconnection from the world. There's one interesting thing in here. You can see a little bump in the middle, and that's when we had a green zone with Australia, because they had achieved elimination all 8 of their states and territories. But that was quite hard for them to sustain for quite complex reasons, because in some ways they never had at a federal level a commitment to elimination. They wouldn't really use that term. They, to some extent, devolved to states to manage their own affairs, which I think is not a great approach with this virus because of the way it can cross borders. But we did have green zones with many Pacific islands, and that worked very well and was sustainable. And I think this is one of the reasons why having globally coordinated strategies is much better than individual countries doing their own thing. So one of the things, of course, is disinformation. And anyone who was a COVID commentator over this period would have experienced this. It's something in public health I'd never seen in my life, because you're used to people, you know, you say nice, friendly things about public health measures, and usually people say, oh, yeah, that's all good, and you don't hear anything else. But suddenly this torrent of truly appalling emails and messages, this is some of the nicest stuff. And I woke up one morning and a group called Voices for Freedom, which was obviously funded from overseas sources, suddenly had my face on billboards around the country, along with some other people. My kids thought this was hilarious, but I was amazed also of the hundreds of things I'd said. The one they honed in on was it was only designed to nudge people towards vaccination. These were vaccination certificates people had to have, which was hardly the worst thing I've ever said in my life. But anyway, that idea of some coercion behind vaccination, and I think nudge is probably the right term, because it was never compulsory, really obviously antagonized the anti-vax group. And up here we had a slogan, we're the team of 5 million, and some of us became the team of 5 tyrants. And this is a well-known right-wing blogger, Cam Slater. Could Michael Baker be any wronger? Yes, I could be. So one of those, I mean, there are some silver linings. One positive for us was that a philanthropist who liked the fact we were speaking out on the pandemic gave us a large bequest to set up a communication center, which we're busy utilizing now. And so that was a positive for us. So what does this mean for the future? I'm sure, you know, all the infectious disease epidemiologists in the world are probably sitting down in little huddles thinking, what's next on the horizon? And this is one of many ways of trying to classify the threats. And this is looking at the combination of low and high case fatality and low and high transmissibility. So you very quickly get to that quadrant of familiar things to worry about. Flu pandemics, smallpox if it was recreated or liberated or released. Emerging disease X just covers all the things that can leap from the animal world, these spillover events. And unfortunately, I think we do have to plan for novel synthetic diseases, you know, bioweapons, because the technology is becoming so available to alter and even assemble microorganisms from basic reagents. So one of the proposals, and this is a short article we published in The Lancet in January this year, is that basically the World Health Organization, when they identify a public health emergency of international concern, they assign a response strategy to that. And we think that elimination should be the default option, unless there's good reasons why it can't work. And this is obviously, the goal is eliminating its source. That has to be top of the list, and then delaying spread. And while you can implement other control measures. And the international health regulations, I don't know if you're familiar with them, but that's the agreement under which WHO operates to declare public health emergencies. And that could be is being reviewed at the moment. I think it could contain this change. And these are some of the reasons why I think it's actually a lot easier to do than it might sound at first. We're already using elimination for lots of infectious diseases. This idea has been proposed before, I think with quite good thinking behind it. It can work in low and middle income countries and those with complex land borders. I think it's feasible and desirable for most of the emergencies we've had to date. And there's always scenarios that you can come up with where I think everyone would agree we have to eliminate that. We cannot cope with a pathogen of that severity. So just looking at these a bit more, we've obviously eliminated some global pathogens already. We're on the way, hopefully, with polio and some others. But we have regional elimination strategies now for lots of infectious diseases. Even HPV and cervical cancer is actually a WHO strategy. But there are others, Hep B, Hep C, obviously measles, rubella. We've got vaccines and antivirals and screening methods and other approaches where this could be the great decade of elimination for many infectious diseases. The only thing that's unusual here is we're doing it for a pandemic disease, but of course polio is also a pandemic disease. So it's actually not a huge leap to take this approach. This is one paper it really stuck in my mind from the 2005, and that was when the world was very worried about avian influenza. I mean, we still are, but this was a modeling study by Neil Ferguson and co, saying, well, if we got an outbreak, and this was simulated in Thailand, if you threw prodigious quantities of antivirals at it, plus some physical distancing, it was possible to eliminate it at source. So this is getting in very quickly. So it's not a new idea. This is also, I'm obviously have to declare my biases. I'm from a small isolated island surrounded by water, so elimination is a lot easier to contemplate. And we did have a lot of things on our side to make it easier. It was easier in Australia and Singapore and Taiwan. And I think Taiwan probably had the best response of any country. And we've done a lot of work comparing notes with them. But in that first year, it was also being rolled out by a whole lot of countries in Southeast Asia. It was actually the dominant strategy in the Asia-Pacific region, even though the World Health Organization never used the E word, even though it was protecting over a third of the world's population, if you include mainland China. But you can see it on this axis, it's showing how, again, countries in our region kept mortality at very low levels well into the second year of the pandemic. And they, on the face of it, did not have many logistic or geographic advantages, but they were able to do that. And this is a bit of a thought experiment. If we look at the last, we've had 7 of these fakes, public health emergencies to date, and Ebola came twice. And this is saying feasibility and desirability, how good is it? I think we'd all agree it's desirable for all of these things to get rid of them, possibly with the exception of H1N1 influenza in 2009, which had only the severity of seasonal flu. But I think the rest we'd agree. So it really comes down to feasibility. Can you do it? And I think it's a given for polio. I think it's also interesting that many countries eliminated flu without using elimination of COVID-19, just because of the seasonal flu actually has quite a low reproduction number. And again, Ebola and Mpox, countries outside Africa where it's endemic would of course not want to have this virus become established. I think that would be agreement, and actually are succeeding in eliminating it at the moment. I think the countries with an X there, red X, are ones where there are animal reservoirs, and you can't technically eliminate a disease if it's occurring from animal reservoirs, particularly when the animal reservoirs are still unknown in those countries. So that does include a number of countries in Africa. So the Mpox story, I think, is interesting that this is showing the epidemic curve in total. I mean, there'll be huge under ascertainment, but it does look like it has been eliminated in many countries where it was spreading widely. And you can barely see along the bottom there the cases reported in Africa, which will be, again, hugely undercounted. but they have continued on at a fairly similar trajectory. And I think it does look like that would be the preferred approach, although it was never a stated goal. And I think that's a pity, because I think it would be quite a unifying one for many countries. So this is looking at, again, at the last point about why I think elimination has to be, we have to have the discussion, because it's very easy to imagine a scenario where almost every country on earth would agree we must eliminate. And if you imagine that COVID-19 had the infection fatality risk of SARS, which is 10%, I think we would be saying we have to eliminate this, and countries would be doing everything possible. So it's not a matter of whether elimination should even be on the list. It's a matter of when you would use it. And I think that's the discussion we need to be having. So again, sorry, just to run through all the benefits of elimination. It's basically, we know that it's a way of organizing public health and social measures that are very versatile. They can actually stop possibly any infectious disease if necessary. And I find that reassuring now. We've stopped a global respiratory pandemic using these measures in multiple countries. Ideally, you'd eliminate its source, and you can do the thought experiment. Imagine if China and other countries, when they saw this novel coronavirus, people going to hospital in 2019 at the end of the year, they'd said, that's an absolute alarm bell. Our whole system is programmed. It's built into our thinking that we have to eliminate that. Because they could clearly have the ability to do so. I mean, they eliminated it for 3 years, but it wasn't built into their thinking enough, right down to a regional level. And then delaying transmission to reduce harm. Well, if we get pandemic flu spreading, if it has a high case fatality, maybe at the level of 1918, you know that the vaccine can actually be rolled out in huge quantities within 3 months and distributed. And there are stocks already of for avian influenza. So that would be a very quick process. And surely you would be wanting to delay its arrival in your population to do that, because you know it can spread quite explosively. We know there are positive health and economic and human rights benefits if you deliver this strategy well. And the more you do it in a globally consistent way, you can have huge green zones where you can protect even quite vulnerable countries that you have preset trade routes with. And I think if you plan for it, it could work very effectively. I also think it would support strategic investment in low and middle income countries. And I think one of the metaphors, I think, is air travel. And basically, air travel has been made safe to almost every country on earth, even if they're a low income developing country. And there's actually a mountain of international law and agreements and investment strategies to achieve that. And it's because you've got a consistently high standard. And I think, why not apply that to pandemic infections? It would also mean the IHR, its big criticism is that it's just a way of identifying things, it doesn't fix things. So this would give it more of actually a control focus to add in this element. And I think it would hopefully support a more proactive role for WHO, who I think actually showed very poor leadership throughout the pandemic. And I think what was missing was a clear strategic direction and a lot of flip-flopping, and obviously a long list of things about airborne transmission, masks, and you could go on. And they did say you must not do anything at your borders. That was one of their early statements. So I'm not saying it's all positive. There's a long list of disadvantages as well. We could potentially increase global inequities. Harms could exceed the benefits if this strategy is used poorly. It's very hard to measure disease parameters early in a pandemic. This is, people have got this quite wrong. And, if you have this as a strategy, you will get it wrong. If you're going to move very quickly, sometimes you'll be out. But you accept that with any intervention, you have to basically assume that it's not going to be 100% accurate. There are operational issues. Exiting from this is quite tricky. Even with a highly vaccinated population, it was difficult to say when you'd actually allow this virus to suddenly infect people when you spent over 2 years saying, we must not have this virus infecting us. So it's challenging. We don't want to draw resources away from to putting too much effort into infectious diseases that have low impact. And I'm not saying for a second that you'd ever dream of doing this for things like mpox or other things that are not going to spread very widely. And there's always unintended consequences. And one thing I just added after talking to a couple of groups, 2 separate groups said to me, well, how would we test our vaccines and antivirals if we didn't have something circulating? And I thought, okay, I guess that is a problem, a kind of a problem. So I've always loved this saying, a public health triumph, nothing happened, because that, of course, is a sign of success. And I always think it's the curse of prevention, is that, in clinical medicine, you've got grateful patients, obviously, and you can see the difference you're making. Public health, this is the thing we all live with, is that there is not an identified people who are sick or who've avoided illness and premature death and disability. So that's why we have to keep reminding governments, you have to keep investing in this area, because the normal metrics don't always apply that well. And my big message is that strategy, I think, I wouldn't say it's everything, but it takes you a long way closer to a successful outcome. And you need the effective science leadership, and you obviously have to have good political leadership. And we were very fortunate in New Zealand to have a progressive government that prioritised public health, a very able Prime Minister who understood the science and was a very good communicator. So you unfortunately can't always have one of those. So we're very disappointed to lose her, and where she's resigned, of course. So I think I've probably already laboured a lot of these points about I think, remarkable legacy of for me, 2 of them in the first year was that you can stop a respiratory pandemic with basic public health and social measures, and also the speed of vaccine development were 2, I thought, triumphs for science and public health. And I think the benefits, obviously, it's eliminating its source or delaying transmission. Delay is good with new novel infections. The more coordinated the strategy is, the easier it will be, the lower the cost, the more you can build it into your planning. And as I'm suggesting, a simple way is to build it into the international health regulations. That is still a really outstanding global agreement, but I think it needs more focus, and this could achieve that. I just want to acknowledge the fact I was brought to Norway by this group, the Centre for Advanced Study, to work on one particular project, so that's why I'm here, and also a wonderful group of colleagues. Thanks.